presentation today is arrhythmogenic right ventricular cardiomyopathy. The reference, which I have detailed at the end last slide, is a chapter from my is a chapter that I wrote in a book called Cardiomyopathy, Disease of the Heart Muscle, and it has been edited by Dr. Gustav Mattsson. I will present the link at the end. So what is ARVC? Can anyone tell me what is ARVC, or do we use a different term now? No one? So ARVC is, again, arrhythmogenic right ventricular cardiomyopathy. It is also termed as, it used to be termed as arrhythmogenic right ventricular dysplasia. And it's also termed as arrhythmogenic cardiomyopathy now. And I will get into why it's called so slightly into the presentation. It is a genetic form of cardiomyopathy which causes fibrofatty replacement of the myocardium. So the main form that was found out originally was found out to be autosomal dominant. It's a myocyte adhesion disorder, and it, unlike the name suggests, it has been found that it affects both the right and the left ventricle, and it can cause to biventricular failure, which is one of the presentations. It has a male to female preponderance of 3:1, and it's the second most common cause of sudden cardiac death in population less than 35 years. On the right is a picture of heart of a 37-year-old woman who was admitted with heart failure. As I was mentioning, people are admitted with biventricular failure. Unfortunately, she went in to have a cardiac arrest, and the heart here, if one can see where the white arrow points, it effectively shows that it points towards the fatty infiltration in the right ventricular wall. A little bit about the history. In 1736, Giovanni Maria, who was a Pope's physician at the time, was the first to coin this term. The symptoms being found in family members being palpitations, heart failure, and they went on to have aneurysms of the right ventricle and sudden cardiac death. The epsilon wave was one of the first electrocardiographic features of the disease, and it was mentioned in the year 1984. And it was also acknowledged soon after that it's one of the sudden causes of death in the young. Rampazzo et al. Went on to find the ARVD1 to be the first gene locus and map it on chromosome 14. In 1995, the WHO's classification was revised, and the dysplasia it was coined as cardiomyopathy. And the reason for this was that myocyte apoptosis was seen, and that's why. And I was mentioning that, you know, how dysplasia was recoined as cardiomyopathy. So this is how it was reclassified. The different things that were being that were coming up led to it caused the need of an international registry, and one of the genes that was first to be put into it was the deletion gene that encoded the plakoglobin gene. It actually was found in the Naxos Island, and it caused and it was the cause for the recessive variant of the disease. Other defective genes which encode cell junction proteins like desmoplakin, plakophilin, these actually they were more associated with the classical form or autosomal dominant form of the disease. Coming to the genetics, as we already discussed, it is mostly inherited as a dominant Mendelian disease, although recessive variants exist. The linkage analysis supported the genetic heterogeneity for the multiple ARVC loci on chromosomes. Some of the examples are chromosome 1, 2, 3, 6. Desmoplakin gene was the one that was one amongst the first to be found out, and it is related to the autosomal dominant variant of the disease and causing ARVC type 8. The Naxos disease we mentioned earlier, it was mapped on chromosome 17 and related to the junction plakoglobin gene. Cutaneous and hair follicle involvement in the autosomal recessive form led to identifications of mutations in desmosomal proteins, plakoglobin and desmoplakin. A recessive mutation of the DSP was associated with the Carvajal syndrome, which is another form of cardiocutaneous disease, and it involved the PKP2 protein. Extradesmosomal genes were involved with the autosomal dominant form of the disease, like this cardiac ryanodin receptor gene and the transforming growth factor beta-3 gene. Coming to the histopathology, as we discussed, it's essentially the fibrofatty replacement of the myocytes, which causes to thinning of the wall. It is described as seen in right ventricle because that was the first one that was discovered, and it was only later on that we found out that both the ventricles are involved in this. The process usually moves from the subepicardium to the epicardium. Most commonly involved area of the right ventricle is called the triangle of dysplasia, and this is why the term dysplasia was used as to define the disease at first. It involves the apex, the infundibulum, and the right ventricular inflow area. There was a forensic autopsy study of 20 patients, and in that it was found out that the right ventricle, in 45% of patients, the entire thickness of the wall was affected, and in 27, the outer half was affected. In the rest of the patients, the outer 2/3 of the walls were affected. Angeline et al. Suggested that when there's more than 40% of fatty tissue present, it is highly suggestive that the disease is present. Later on, studies showed that left ventricle is involved in up to 76% cases in these reports. In the left ventricle, the septum and the free wall are affected, and they can be either affected regionally or diffusely. And it's highly likely for the posteroseptal or the posterolateral areas in the subepicardial and the mid-ventricular wall to be affected. If someone looks at the histologic pictures on the right of the screen, the first one on top, it shows myocyte death, and the one below, it essentially shows fibrosis and infiltration of fatty tissue or adipocytes. Inclusion in the WHO classification of cardiomyopathies, which I talked about earlier, how it was recoined as a cardiomyopathy. It was based on clinical characteristics, the pathophysiology of myocyte apoptosis that I mentioned earlier, and postnatal development and genetic background. The pathogenesis consists of different suggestions. For example, congenital defects, genetics, and acquired factors like viral myocarditis. Approximately 30 to 50% of cases, in 30 to 50% of cases, autosomal dominant pattern of inheritance is seen, and there can be incomplete penetrance and variable expression. The fibrofatty tissue causes ventricular arrhythmias, by slowing the intraventricular conduction. This is essentially related to the scar macro entry mechanism. At molecular and cellular levels, loss of expression of desmosomal proteins may cause potentially fatal arrhythmias. Clinical presentation. Please look at the picture on the left side of the screen at the bottom. It's an MRI in a patient affected by ARVC or ARVD, and it essentially shows the bright signal is the right ventricular free wall, and it's lit up because of the massive myocardial atrophy, and that it has been replaced by fatty tissue, and that's why it lights up, because fat lights up in this sequence of MRI. And on the right, we can see ECG and MRI of a 17-year-old asymptomatic male athlete who died suddenly during a soccer game. We can see in the ECG marked as A that there are inverted T waves up to V4. And if you look at the ECG below, you can see isolated premature ventricular beats. The MRI shows right ventricular dilatation and aneurysms in the anterior and posterior walls. Clinical presentation. So people who have, there can be subclinical concealed structural abnormalities, and that's why the last, the picture that we saw on the right, it said asymptomatic male athlete. The patient suddenly presented with SCD or sudden cardiac death. So these are the causes of subclinical concealed structural abnormalities. When patients present, they usually present with overt electrical disorder like palpitations or syncope, or they can even present with heart failure and subsequently go on to have cardiac arrest, as the first patient we discussed. Diagnosis. Diagnosis can be a bit tricky. In 1994, an international task force proposed guidelines in the form of a qualitative scoring system with major and minor criteria. In 2010, the guidelines were revised to improve diagnostic sensitivity. This provided quantitative criteria for diagnosing right ventricular abnormalities and adding molecular genetic criteria. I'll just move on to the next slide before I come back to this one. This shows the revised 2010 task force criteria for diagnosis of ARVC/ARVD. And it essentially takes in major and minor criteria in a few domains. Number one being global or regional dysfunction or structural alterations. Number two being histopathology. Number three, repolarization abnormalities in 14 years of age, and depolarization abnormalities, arrhythmias, and family history. I'm not going to go into the details of the criteria, and I apologize that this particular slide is a bit cramped up. Going back to the previous, slide, diagnostic difficulties can be there because there's low specificity of echo abnormalities, because we have to consider the multiple causes of right ventricular arrhythmias. There can be difficulties in the use of imaging to assess right ventricular structure and function, and sometimes the genetic test results may be a bit puzzling. And diagnosis is particularly difficult in children. Diagnosis is mainly done by cardiac MRI. There are diagnostic dilemmas that can actually make the diagnosis even a bit more trickier. And Some of them are cardiac sarcoid. There can be congenital heart diseases leading to right ventricular volume overload, or right ventricular outflow tract leading to tachycardia, or causes of dilated cardiomyopathy, which includes both the ventricles. Risk stratification is a very important bit in this disease, in which a lot of knowledge is yet to come out. The estimated overall mortality varies among studies, ranging from 0.08 to 3.6% per year. The prognosis depends on the severity of the arrhythmias and the ventricular dysfunction. The most important predictors of life-threatening arrhythmic events are prior cardiac arrests due to ventricular fibrillation or sustained ventricular tachycardia. Major risk factors can be syncope, non-sustained VT, severe systolic dysfunction of RV, LV, or both. And I think this is why we need to follow up patients quite strictly. Traditionally, intracardiac electrophysiological testing has been used to assess the risk of ventricular arrhythmias. Ventricular tachycardia or ventricular fibrillation induced by programmed ventricular stimulation is still of unclear prognostic value. Coming to management, I think the heart of the management essentially rests and the aim is to reduce the risk of sudden cardiac death and to improve the quality of life by alleviating arrhythmic events and heart failure symptoms as much as we can. There are preventative measures for this, and where we advise patient restriction from intense sports activity, and we follow patients up every 2 years. Now, why do we follow patients up every 2 years? Because there is age-related penetrance and progressive nature of the disease. And that's why one of the criteria there mentions in repolarization criteria, there's age-related criteria of 14 years of age. Medications we use to maintain, to keep the arrhythmias in check: beta blockers, amiodarone, sotalol. Other options are ICD placement and treating congestive cardiac failure symptoms. In patients whom we cannot manage by these measures, catheter ablation is what we could essentially look to as one of the other options. However, cardiac transplantation remains the ultimate therapy for refractory CCF and untreatable arrhythmias. Regarding research, I think there is yet a lot of study to be done. There's no study being done in humans yet. However, there has been some promising evidence in zebrafish and rat, where small molecules, which are activator of WNT signaling pathway, have shown promises to prevent or reverse phenotypic manifestations of the disease. To sum up a little bit about what we talked, because it was obviously I had a time slot and I had to tell a lot in quite a small amount of time. So just to sum it up, the take-home message essentially is, it's a genetic form of cardiomyopathy which causes fibrofatty replacement of the myocardium. It is mainly the major variants are autosomal dominant. Also, there are recessive variants that have been found with a male to female preponderance. Desmoplakin gene is one of the most important genes and one of the first to be found out. It's a myocyte adhesion disorder. It's the second most common cause of sudden cardiac death in the young. The pathophysiology includes myocardial atrophy, fibropathy replacement, and chamber dilatation. The main take-home message is it presents a great diagnostic challenge. Therapeutic options are based on preventing life-threatening arrhythmias, and there are both primary and secondary prevention. In the end, I'm very thankful to my lovely family, my parents, and my husband for their support. And the highlighted bit in red is the chapter in the book that I have written. And you can follow the link. It's an open access book, so you can follow the link and have a look at the chapter if you want. And I've set forth a few references that I have used to write this chapter, and also to present to you today. Thank you so much.